A very pleasant morning to one and all. Today, on October 29th, World Stroke Day is celebrated every year. The Global Awareness Day was established by World Stroke Organization and provides a global platform for the stroke community to increase awareness and drive action on stroke around the world. So, Parul Institute of Physiotherapy, Parul University, has organized health talks on stroke management, a holistic approach. Post stroke management is a patient centered, goal driven process that attempts to maximize the functional independence of patients who suffer from a variety of stroke related disabilities. Rehabilitation is derived most effectively and efficiently by an interdisciplinary team comprised of healthcare professionals working together to achieve common, shared goal for a patient's rehabilitation. Constant and effective communication between team members and the patient allows for a holistic approach. So, I, Simra Pathan, on behalf of Parul Institute of Physiotherapy, Parul University, welcomes you all for the panel discussion. It is my honor to invite our panelists for the health talks. Starting with Dr. Nilma Patel Ma'am. She is the Honorary Director of Parul Institute of Physiotherapy, Parul University, ex-principal and head of Department of Government College of Physiotherapy, SSG Baroda, and a fellow member of an Indian Association of Physiotherapists. She has done PhD and has also done PG diploma in clinical and community psychology. She has completed Yoga certificate course and Yoga teacher training course and also participated in more than 25 national and international conferences. She is the author and editor of Yoga and Rehabilitation book. She has been awarded with Physio Ratna Award twice, Lifetime Achievement twice, Rashtriya Gaurav Award for integrating science and spirituality, and many more. As you can see, there are multiple accomplishments she has been achieved in various disciplines and fields for which she has been awarded. Welcome, ma'am.
Thank you.
The next panelist is Dr. Ankit Shah sir, and he has done MBBS from Baroda Medical College and MD Medicine in MP Shah Medical College, Jamnagar, DM Neurology from SM Medical College, Jodhpur, and is currently working as consultant neurologist in Parul Hospital from 2017. Welcome, sir.
Thank you.
Our third panelist is Dr. Mahesh Prapagodra sir. He is the assistant professor of Department of Panchkarma of Parul Institute of Ayurveda, Parul University. He has completed PG from SDM Hassan College, Karnataka, and currently doing PhD in Parul University. Till now, he has presented papers at 5 international seminars and 8 national seminars. Totally published 28 articles. We welcome you, sir.
Thank you very much.
With this, let's start our panel discussion with our first panelist, that is Dr. Ankit sir. So, sir, I would like to ask you about which are the common risk factors of stroke as the incidence rate of stroke in middle ages increased. So, according to you, can you please share some brief idea on it?
Yes. Uh, the common risk factor which we see in patients for any type of stroke, that may be hemorrhagic stroke or ischemic stroke. The common risk factors are hypertension, diabetes, tobacco use in any form like smoking or tobacco chewing, then hypercholesterolemia or dyslipidemia, then alcohol intake. These are common risk factors, and these are traditional or not modifiable risk factors. Some non-modifiable risk factors are also there, like age. Increasing age is an risk factor. Then gender. Less than 50 years of age patients, male patients are more predisposed to stroke than females, and after 50, the ratio is somewhat same. Other than that, some genetic factors like familial hypercholesterolemia is in which we can't modify that risk factors. Other than this, racial factors and ethnic factors are also there. Among these, some new factors emerged in last few decades, like sedentary lifestyle, uh, like sitting nowadays. Many young, most of the young population is having laptop work, sitting work. So that leads to a new risk factor that is as harmful as smoking. It is proven in studies that if you sit for 8 hours in a day daily, it is equal to smoking 10 cigarettes per day. So this sedentary lifestyle, then change in food habits. This change in food habits also, like we are now westernizing our food habits, and our genetics are not so ready for that big, rapid change in food habits. That leads to certain type of dyslipidemia. Like in our population, LDL is not seen too much high, but in our population, triglyceride is seen high in most of the dyslipidemic patients. This change in food habits is also considered as risk factor for stroke, and increasing burden of diabetes in recent past few decades. That also leads to higher stroke risk. Other than this, the risk factor increases in some cardiac conditions like valvular heart disease, low EF ischemic heart disease, where cardioembolic risk factors, stroke risk factor is high.
Thank you, sir. A lot of modifications we need to do in our lifestyle now. Moving forward to our next panelist, Dr. Nilima Patel, ma'am. Ma'am, as many times we see the patient is wrongly positioned while they are at home or in the hospital for a long time. So, can you give a brief idea about what is the importance of positioning in this acute CV stroke patient?
Yes, very important question and the situation to be noted down. Uh, we as physiotherapists are aware that movement begins in a posture and ends in a posture, and rehabilitation starts from day one itself, right? So many times, what happens? The whole attention is when the person is in ICU or in an acute care hospital. Most of the things happen around saving the life or taking care of the secondary medical complications. So the head and neck position is neglected. So what is affected is the muscle tone and not the postural tone. So right from day one, if the postural tone is taken care of, we can prevent all abnormal tonic reflex activities, of which TLR supine, tonic labyrinthian supine, is one of the main reflex that we have to take care of while the person is in an acute care setup. So you can place a small pillow under the head and neck, provided there are no problems of intracranial pressure increase. You have to discuss it with the neurophysician and then modify the things. Or you can place a pillow under the scapula. So your main aim is to prevent abnormal reflex activity during the acute stage. Another important thing, the approach should always be from the affected side. Why? Because we want to encourage cross facilitation techniques, cross facilitation methods or maneuvers to give a very good proprioceptive input to the affected side. So when the person is approached from the affected side, you are taking advantage of the proprioceptive feedback. So nursing care or feeding or communication or the relative all needs to be made to sit and communicate from the affected side. So automatically that will take care of the head, and you may prevent at a later stage asymmetrical tonic neck, because everything will depend on the site of lesion, the severity of lesion, the type of stroke, and so many things. But these basic things, if they are taken care of right from day one, I think so. We are giving attention to the postural tone, and we are trying to prevent abnormal tonic reflex activity. If at all primitive comes up as a recovery pattern, we are helping to integrate right from the initial phase. So it's a very important thing. And why to remember this? Movement begins in a posture, and spasticity or hypertonicity is always in group, never in one muscle. So taking care of all these things, positioning in acute stage, is very, very important to inhibit abnormal reflex activity, tonic reflex activity. There are many things, but I think so. Just to give you a guideline on this area.
Thank you, ma'am. These things must be keeping in mind while treating patients to see the early recovery in the patients. Ma'am, what are your views regarding splints in post-stroke patients in early rehabilitation phase? Is it beneficiary or harmful? Can you please enlighten us on this?
Yes, again, a very subjective question. It has to be discussed a lot before you prescribe any type of splint. Okay, the main thing is whether you are dealing with the person in a recovery phase or in post-recovering phase or a residual phase or a chronic phase. It will all depend when are you intervening or when are you planning to give a splint. Another important thing, it will depend again on the severity of the lesion and extent of lesion and what time elapsed between. So nowadays, this is the era of CT scan and MRI, so you come to know how vast the lesion was. But definitely new interventional surgeries and pharmacological agents are being introduced. So the consequences of abnormal activity can be prevented by early bed mobility, early activity, weight transference, rather than splinting apart, right? Because as it is, we are all aware that stroke is a problem of movement and not the muscle power. And what is important is early mobility and transfer. So if you splint without proper evaluation, I think so we are limiting the early activity, participation level, and concentration level in that person. So as I said, it is very subjective, but I personally feel if you are treating a case, if you're handling a case, you're approaching a case in a recovery phase, early intervention phase, then definitely splinting should not be given. You can give a dynamic brace, but with thorough assessment, because every assessment is a treatment and every treatment is an assessment. So try to think twice before you give splintage, because we want mobility, we want movement, we are movement therapists. So mobility and movement are our key elements. So splintage, if given unwise, can lead to negative consequences. And many times it is understood giving a splint is a passive support. No, sometimes in a flail limb, if you want to go for early weight bearing, that time if you go for splintage and you give early weight bearing, you are triggering good postural reflex, you are triggering good postural control. So in that case, splintage is necessary. But suppose you are not, you have not evaluated properly, and suppose you want to give a hand splint, you have not taken care of abnormal tonic reflex activity, and you give a splint, so it becomes a forceful way of positioning. So any type of forceful activity is going to increase hypertonicity. So see, so many things have to be considered before going for a splintage, even in acute stage. Before splinting, please try to assess, is there any dominance of abnormal reflex activity? Is there any persistence of primitive activity? Then think of giving a splintage. If there are no such abnormal reflex activity dominant, then definitely if your aim is to just prevent some spastic tightness or muscle imbalance tightness, you can give as a night splint. If your aim is to give prevent tightness or contractures, but not in a case of a recovering patient.
Thank you, ma'am. So the next question I would like to ask to Dr. Mahesh, sir. Sir, as our physiotherapy students in Ayurveda department treat stroke patients, and patients usually say that they went for Panchkarma treatment. So can you please tell us in brief about Panchkarma and on what principle it is working and its indications and contraindications for the same?
Thanks for asking the questions. And this is, I thought, basic question to be known to each and everyone. Here in Panchkarma, as of now, it is a part of, as we all know, it is a part of Ayurveda. And when you consider the whole Panchkarma, in Ayurveda, there are three kinds of treatment protocols. One is to elevate or to set the apart of positive factors, and another is internal medication, and the third is Shodhana, that is Panchkarma. And major part of the all diseases which are explained in Ayurveda are being treated, are being told to get treated through the Panchkarma. And in Panchkarma, as name it suggests that it is having five main karmas. and these karmas are meant for biopurification. That means whole body purification. We do have thought that our whole body principles are being understood by the three doshas, that is Vata, Pitta, and Kapha. And mainly the Vata is meant for all bodily movements, which we can take as a standing, sitting, walking, or talking. Whatever the movements done by our body is considered by Vata dosha. And when it is in normalcy, the whole body works as proper. And when it is get affected by any of the positive factors, as sir earlier told, these are been same told in Ayurveda also many years back. And if it is if it got affected, then it will hamper the particular part of the body. And according to that, for vata dosha, there are around 80 set of diseases called told or explained in Ayurveda. And this stroke comes under that vata valley. And here for Vata Vyadhi, the Chikitsa is, or the treatment protocol is meant to be a Nasya Karma, Basti Karma, and Virechana Karma. And when we talk according to the according to the Panch Karma, initially we start with the Virechana Karma, which is meant for purgation therapy. And then we will shift to Nasya Karma, that is installation of medicated liquids, rather we call it as oils or the krutas, into the nasal cavity. And at the last, we go for Basti Karma, that is medicated enema therapy. And it has been told in our classics that the Basti Karma holds the half part of the whole treatment protocols explained in the Ayurveda. And whoever they are getting admitted for Panchkarma therapies, they are itself considered for the Basti Karma in Ayurveda or in our hospital. So whenever the physician asks a rogi or the diseased person to get admit, it itself means that the person is meant to take Basti Karma in Ayurveda. So, and according to what you asked regarding the contraindication and indication, here initially, as we all know, ischemic and the hemorrhagic type of paralysis we came across, and in both we adopt the same protocol, but in different way. If it is ischemic, then we will go with the majorly go with the Nasya Karma, and if it is hemorrhagic, we will majorly go with the Basti Karma. And if at all patient is having semi-comatose condition, and he is not as such normal, as he is not replying to the any verbal communication, then we will go with the Shodhana Nasya, that is installation of medicated drops or the medicated powders through the nasal cavity, which from which the patients get back to the normal state, and he start responding to the verbal stimuli. Though he is not replying to the sentences or he can't able to speak, still he will move his hands and affected part through the therapy within 1 day or 2 day. And after getting back to the getting back from the comatose condition, then we will start with the normal protocol, that is the Basti Karma or the initial same Nasya Karma. And main thing that why the vata dosha effect here, it's due to the vata prakopa, and this vata prakopa happens, or the visheshan of this vata dosha happens due to our dietic behavior, our diets and regimens which we routinely adopt. As sir initially told, all are considered same as such in Ayurveda also. And major part, if the person is having constipation, then all these symptoms will trigger enormously. So for that reason only, to elevate the constipation, we do adopt this purgation therapy, that is the therapeutic purgation therapy, and it is in controlled manner. It is not as such that we are adopting this purgation therapy for around 20 times or 10 times like that. We are just need to get around 3 times or 5 times of purgation in that patient initially. Then after elevation of that purgation, after elevation of that constipation, then we will shift to whole these kind of things, that is Nasya Karma and Basti Karma. So, if at all I am start telling you regarding the each and every aspect, you will not get to get the correct meaning, and it's just a highlight of our therapy. And apart from that, there are other therapies, that is external therapy, where we call it as a Abhyanga and Svedana Karma. And here, if the patient is having a much more spasticity, then we will shift him to generally to massage, body massage. Then with the sedation therapy, that steam therapy, that Abhyanga and steam therapy, that spasticity will decrease day by day. And after that, with the help of the Basti Karma, his muscle power get strengthened, and his neural mechanism, which has been hampered, that also start coming towards the normal. This is the whole protocol. And regarding indication, as I earlier told, all types of these strokes are indicated for Panchkarma. Only in contraindication, if the patient when got admitted get further deterioration, then we will shift him to ICUs, modern therapies. Then if the patient is having head injury or any accidental cases are there, or there is a requirement of surgical intervention, then we will not give the Panchkarma therapies, any Panchkarma therapies. And regarding the responding mechanism, if the patient is not responding to our treatment for about 7 days or about 8 days, then we will suggest him to go to another round of modern therapy. Then only we will get him admitted afterwards.
Thank you, sir. Uh, this clears little bit or clears the idea about the punch karma to the students who really ask about this. As we have seen that patients after the onset of stroke brings to the hospital late. So, Dr. Ankit sir, can you please explain in brief if the patient comes after 6 hours of onset of stroke, what is the management?
Okay, a very good question. Because we are now we are focusing on early management of stroke, that is within 6 hours. But it is also important that if patient comes after 6 hours, we have to mainly focus on prevention of recurrent stroke and complication of stroke management, as well as guiding patient for further lifestyle modification. So, if patient is coming after 6 hours, we have to first do A, B, and C. So, to save patient's life. Second, we see for any lesion, that is infarct or hemorrhage. If it is very big and patient is unconscious, then immediately we have facility to decompress that. That we just do decompressive craniotomy and we can save patient's life. Then, according to that, if patient is having ischemic stroke or hemorrhagic stroke, if most of the 85%, sorry, 80% patients are having ischemic stroke, so we will more concentrate on ischemic stroke. If patient is having ischemic stroke, we have to just stabilize him and start antiplatelet therapy to prevent further deterioration. Along with that, statin therapy is given in all the patients. Uh, from there, the important aspect of stroke management is BP management. The blood pressure management in stroke is very much important to maintain cerebral perfusion pressure of brain. What happens when patient is having stroke? Patient's body try to increase blood supply to the brain, and in that attempt, patient's body increases blood pressure by its own. In our guideline, if patient's blood pressure is more than 230 by 130, then only we give antihypertensive in acute phase. In acute phase, may prolong from 24 hours to 48 hours. So, if patient is coming after 6 hours, but before 48 hours, and his BP is less than 230 by 130, we will not give him antihypertensive. Only if BP is more than 230 by 130, then only we will give antihypertensive. This is very much important part, because in many of the patient, what happens if they are given antihypertensive, the BP is brought down to 150 or 160 or 170, then that cerebral perfusion pressure, the pressure which is needed to supply blood to the brain through narrow arteries, through atherosclerotic arteries, is decreased. So stroke, we control BP and stroke will increase. The tissue which is damaged, the part of tissue which is damaged is increasing. So this is somewhat paradoxical. Second part, sugar management, sugar and temperature. These are two factors. If not managed properly, this may increase the damage. So RBS every 4 to 6 months is recommended. Other than this, hello, hello.
Yes.
Other than this, we need to focus on management of prevention or complication. The complications which are common, they are sepsis, like stroke patient in ICU is having many lines like IV line, catheter, rise tube, which all increases the chances of sepsis. So prevention of sepsis, prevention of bed sore, prevention of deep vein thrombosis, prevention of recurrent stroke. These are very much more important. Prevention of brain edema. These are very much important. And along with this, we are going to integrate physio and panchakarma along with that to increase chances of recovery in that patient. After 5 to 7 days, when acute stroke period is managed and patient survived, then we begin all this multidisciplinary approach to increase his recovery, increase his ability to work after stroke. Because as we know, only 20% of patients walk by themselves at 90 days of stroke. If he presents after 6 hours, means we are not going to give him mechanical thrombectomy or IV thrombolysis, then only 20% will walk. But that is that 20% patient depends on our approach, that how early we give them physiotherapy, how early we catch that complications and treat them, how early we treat that spasticity, we catch that spasticity, how early we prevent stroke complications and recurrent stroke management, as well as installing that installing that sense in patient and relatives that stroke may recur. So all modifiable risk factor we have to explain that patient and modify them accordingly, like hypertension, diabetes, addictions. We have to dyslipidemia. We have to manage them, so we can increase chances of recovery, and we can manage that patient and give him the life he was living before stroke, because stroke changes lives and stroke changes nations also. As we know, Atal Bihari Vajpayee was not able to work after he developed stroke, and the scenario may change if he did not have that recurrent strokes, or else that leads to vascular dementia.
Yes, thank you so much, sir. As you have already given about the idea about the multidisciplinary approach also in the stroke patients, including all the fields. So, in rehabilitation, when we see acute stroke patients, there is a presence of abnormal reflexes, which leads to abnormal posture in them. So, is physiotherapy is indicative in and effective in such patients? And if it's effective, then how it is effective? And if we are not advised for physiotherapy, then when we can start physiotherapy?
It is for me, this question.
The question is for whom?
Yes, ma'am.
The question is addressed to whom?
Ma'am, to you.
Okay.
Sorry, please repeat the question.
Ma'am, in rehabilitation, we see acute stroke patients with abnormal reflexes presence, which leads to abnormal postures. So, is physiotherapy indicative and effective in these patients?
Okay, yes. Definitely, as I mentioned in my last answer also, that brain appreciates movement and not the muscle power. And we all are aware that whenever a stroke happens, the first thing that person will suffer will be at a psychological level. And whenever there is a stroke, it's just not the physical problem. There are so many issues coming along with the physical problems. There could be communication problems, there could be behavioral problems, there could be emotional problems, there could be social problems. There could be a spiritual problem. The self-esteem goes down and all that. So it's just not the placement or the position of the limbs that is going to take care of that abnormal reflex activity. Simultaneously, we have to address all these issues also to prevent this abnormal reflex activity that is dominant. And the first important thing that I mentioned was with position. Along with that, the placement, along with that, the communication, along with that, the transfer activity. All these activities definitely will take care of prevention of abnormal reflex activity. And one of the main posture, after discussing with the neurophysician and after the medical status get stabilized, intracranial pressures are not an issue, blood pressure changes are not an issue, I would rather prefer to prevent all this abnormal reflex activity in any form. Is one of the main posture that we should encourage, maybe right from day one, day two, as I said, again with discussion. If there is right stroke and if there's a big hematoma and intracranial pressure problems, again with discussion, you can go for sideline position to prevent the abnormal TLR, tonic labile and supine or prone. You are not aware that how is the recovery pattern going to be, whether it is going to be in a synergy pattern, that's a good thing for the person, but if it is going to be a spastic pattern, it's going to be a little bad for the person to come out of that. So sideline takes care of both the abnormal tonic neck reflex activity. So that is one of the thing. And I would prefer, I encourage a lot about starting as early as possible prone lying position. Prone lying, there is a myth that you cannot go for prone lying in the flaccid stage, in a very acute stage. No, but see here we are dealing with oxygenation, we are dealing with nutrition, we are dealing with hydration whenever we are talking of stroke management. And oxygenation is one of the main thing. So I would prefer prone lying to be started as early as possible, taking care even the way and mechanism of turning, but at least for 3-4 times in a day in during the early intervention phase. If prone lying is given, you are constantly monitoring the blood pressure, intracranial pressure, and the other parameters. I think so. It works best to prevent all types of tonic abnormal reflex activity. It facilitates normal postural control. You are going for bilateral activities at a time. You are taking care of the key points of control, the spine, the shoulder girdle, and the pelvic girdle. So, right, rehab starts from day one itself. So, prone line takes care of all these areas. And most important aspect, prone line improves, there are so many research articles, prone line improves the quality of the penumbra also. So as good the quality of the penumbra, so is good going to be the resolution of that inflammation, and maybe you may shorten the phase of acute positioning. So this is one of the things. Prone is one of the best because it takes care of all the three dimensions of your rib cage. Your full lung volumes can be achieved. So good oxygenation, good elimination, at the same time preventing tightness and contractures right from the early stage, prevention of abnormal reflex activity, facilitation of postural control. So I think so prone lying is one of the best to enhance the rehab protocol and to prevent the later consequences of disabilities and dysfunctions. Sideline to be started right from the beginning, and prone lying as early as possible once the medical condition stabilizes. So this is what I have proposed, and it has been working very well in acute stroke patients. Many times it happens in nursing hospitals, the patient's bed is kept at one side and the entrance is at the other side. Now, suppose if a person is right stroke, is having left involvement. And if the door is on the right side, so constantly the unilateral neglect increases. So it's very important to change the discussion with the neurophysician or the physician. I have done so and it has been done. So the person is constantly seeing who is coming, who is going. So even if we really want to prevent unilateral neglect of the person, early positioning and early abnormal reflex activity, all that can also be taken care of. So small things needs great address. Now another important thing, we all are aware, suppose if it is a decorticate type of presentation, and we are aware that there is going to be an extensor spastic pattern of recovery, or maybe an extensor synergy pattern of recovery if the patient is in a good status. It's better, it's very important, right? From day 1, day 2, day 3, you try to keep the affected leg out of the bed, knee hanging down, and foot placed on the small climbing stool or a table. So you are preventing extensor and adductor pattern right from the beginning, because brain relearns the movement. So if a movement is relearned in a wrong way, because you don't know how the patient is going to come out of, it will all depend on how the medical condition is resolving, right? So even taking care in supine position, it is important to take care of that extensor spastic pattern which is likely to develop. As you are taking care of placing a small pillow under the scapula to prevent the retractor, you are keeping a small pillow under the head to prevent neck extensor. All these things definitely play a very important role for early mobilization and early rehab to lessen the consequences of disabling situation. Along with that, communication, because communication skills act like pulse and heartbeat. So as good the communication with the patient starts with by the therapist, it gives a very good result. Along with that, suppose we are aware the hand grasp, the person may come up with a pathological grasp or a primitive grasp. If he is or she is recovering case, then definitely it's going to be with the primitive. And if it is a very bad lesion, the person is going to come up with a pathological grasp. So the hand shake position, all the while maintaining the thumb into abduction and opposition, definitely will prevent a very bad disabling spastic hand. So that also is so whosoever approaches to the patient definitely holds the hand, a handshake pattern. There are innumerable things that we need to take care of. While a therapist is going for passive movements, handling is important. The way you handle, the way you hold also is going to, and I always specify brain appreciates movement. Many times I have seen right side is paralyzed, people go on giving movement on the right side, passive or assisted or whatsoever. Go start with mobility of the normal side as much as possible. So this is a sensory motor feedback. Let the person observe. If the person is conscious, aware, attentive, go on giving the movements on the normal side. If this side is still flail, if still the edema is resolving, make the person perform the activities on the normal side. I think so relearning will be better. So go for bilateral activities, relearning will be better. Okay, so positioning, bilateral activity, and communication skill. This all three are very important while taking care of acute strokes or recovering strokes.
Thank you, ma'am. I hope all the attendees are keeping small notes on this, because this is really going to bring a lot of change, which some students are having confusion or not getting results early. Moving towards to Dr. Mahesh sir, as Panchkarma along with physiotherapy is practiced over here at the Parvati Hospital. So, what are your views on this combination therapy for rehabilitation, sir?
Yeah. Thanks for asking again. As because this whole therapy, what we are suggested by our HODs, and this has been suggested same from through our PG days also. Wherever the Panchkarma hospital is there, along with the sidewise, one physiotherapist will be there, and probably in coming days through the ministry only that norms will be coming for the same reason, as because anyhow we are doing our part, and apart from that, if you ask our patient to do the exercise, still he will not do, and due to his negligence. And the same thing, if the is been given to the particular doctor, then when he starts suggesting, and when he start helping the patient with him physically, then it is the work of the patient, and he will take it very seriously, and he will start doing the same things. And here what we observe here is, it is the add-on therapy, and it is been giving very good results. And we are very much thankful to whole physiotherapy team, as because they are here to help our patients, and we are getting good results. Starting from the initial days, only if the patient is complaining of severe pain or severe spasticity, at that time we will wait for around 3 days or 5 days or 7 days. When the pain got relieved, then we suggest them for physiotherapy. If the patient is not having any pain, then we will directly, starting from the day one only, we will start the physiotherapy. uh, as you asked, we are getting very good results here. I and our whole team appreciate your kind presence here for the same results. Thank you.
Thank you so much, sir, for your pleasant words. Moving forward toward Dr. Ankit, sir, what is the acute management, and briefly can you describe on stroke thrombolysis and BP management, as the awareness regarding this is not much. Please share your knowledge on this, sir.
Yes. Management of stroke starts from identification of stroke. So public awareness is much more required for this, to identify early stroke. What happens when patient is having myocardial infarction or heart attack? Everyone knows that chest pain starts and go to dedicated center and get done proper treatment, early proper treatment. Nobody is going to stay at home for 1 day or 2 day with chest pain. Everyone is going to rush there, because there is public awareness about this disease, but stroke is neglected one. So not many patients are coming within 6 hours of stroke, and the symptoms of strokes are very much varied. So patient cannot pinpoint a single stroke symptom. So we have prepared some mnemonics like be fast. Be fast stands for BEFAST. The B stands for balance. If any acute change in balance, that may be a stroke. E stands for eyes. If there is sudden onset of blurring of vision, loss of vision, that may be a stroke. Then F stands for face. If any facial deviation, that may be a stroke. Then A stands for arms. If there is arm or leg weakness, that may be a stroke. Then S stands for speech. Is there any change in speech or lack of speech, means dysarthria or aphasia, that may be a sign of stroke. And T stands for time, that this is a time to rush to the hospital to get acute care. In Hindi, we made similar slogan to increase public awareness. That is bachavo. Bachavo means ba stands for baju. That if limb is weak, arm or leg. Then cha is for chehra. If face is deviated, अगर फेस टेढ़ा हो रहा है, ऐसा कह सकते हैं पेशेंट को. इफ फेस इज डेविएटेड, देन इट मे बी ए स्ट्रोक. आ ब च आ वो. आ इज फॉर आवाज. अगर आवाज चेंज हो रही है, इफ पेशेंट्स वॉइस इज चेंज, then it may be a stroke. And wa is waqt. This is the time to rush to hospital. Why this is needed? Because uh, our traditional or all meta-analysis is giving us one clear-cut figures that if patient is not thrombolized, no mechanical thrombectomy given, then recovery rate is 20% at 90 days of stroke. If patient is given IV thrombolysis, in case of ischemic stroke. Then recovery rate is 40% at 90 days of stroke. And if patient is given IV thrombolysis plus mechanical thrombectomy, if possible, then recovery rate is 60% at 90 days. So, but tragedy is only 1 or 2% patient are able to get this acute treatment. Rest of the all patient present after 6 hours, or they may not be able to get this treatment. Even in developed countries like USA, the rate of acute treatment is not much high, not more than 5%. So this is due to lack of awareness in public as well as in doctors both. So we divide acute stroke care into two parts, that is medical management and second is surgical management. In medical management, if patient is having ischemic stroke and he presents within 4.5 hours, we immediately get done his CT scan. Only CT scan is needed, no much blood test or anything is needed, just proper history. We have forms that just we have to take down. Even sister can do a take down, nursing staff can do take down and rule out all the contraindication. And if in CT there is no hemorrhage, we are sure this is ischemic stroke, and we can straight away give him IV thrombolysis. The two agents are recommended in India for IV thrombolysis. One is tenecteplase, this is newer one, and second is altiplase. Both are having good results, and they are routinely used by us with good results. Second, this is about IV thrombolysis. Second is surgical management. In surgical management, we can go for, as we discussed, if patient is having much more edema, then we can go for decompressive craniotomy. In intervention arm, we have neuro intervention, that is consist of mechanical thrombectomy, and in few cases stenting is needed. What is mechanical thrombectomy? If patient is having large artery involvement, like ICA is involved, middle cerebral artery is involved, its M1 segment, or at the part M2 segment is involved. In posterior circulation, vertebral artery, basilar artery, or in posterior cerebral artery, P1 or P2, at the most P2. Up to this, if any part is involved, any part is having thrombus, the neurointerventionist just go in and just pull out that thrombus. And in few cases, we have to put stent there, but in very few cases, just we pull out that thrombus and keep that patient on good antiplatelets, IV or oral, or in some cases on anticoagulants to prevent further thrombosis there. And this procedure increases the recovery rate from 40% to 60%. For us, that percentage is only 20, but for patient, if he is benefited, it is 100% for him. So this is the importance of acute stroke care.
Thank you, sir. This was really helpful, and I request all the attendees to please share the awareness to your relatives and the community for the Be Fast Mnemonic and Bachao, because this is really important to know by all the and all your relatives can know about this. They reach hospital as early as possible. It will be really helpful, and early recovery is possible in this case. So, another question to ma'am. As during rehabilitation, physiotherapists work on various goals and principles. So, according to you, can you explain the difference between treatment, therapy, approach, and rehabilitation in post-CV stroke management as a holistic expert?
Yes, a very nice question, very close to my heart. because I am dealing with the holistic care. And when I am talking about holistic care, I always spell it as WHOLISTIC, whole, the body, mind, spirit, all the three. Coming to the word treatment, definitely, initially the word used was treatment. It is sometimes too technical, it is generalized, and it takes care of the physiological aspect of one's illness. Suppose if you're giving a medical treatment, you're prescribing some medicines for typhoid or for malaria. So it's a common dose. The clinician, definitely the physician evaluates the things, but definitely okay, if you have a headache, what is the treatment? Okay, you take a crocin or you take a painkiller. So that is treatment, taking care of the biological aspect of one's problem or the physical aspects of one problem. That is treatment, right? So I always feel that we should not use the word treatment when we are dealing with any neuro rehab or maybe any rehabilitation program. Could be a musculoskeletal, could be women's health, could be cardio, could be respiratory. For us, the word is therapy. Therapy has a great meaning. So it's a physiotherapy. See, initial some places it is called as physical treatment, but it has been modified as physiotherapy. Why therapy? Therapy is the literal meaning is therapy means care, to give comfort, to give security. And when we say therapeutic exercise, they are just not physical movements. They are individualized, customized plan of approach which takes care of physical as well as mental condition of the patient, and along with that posture and body activities are taken into consideration. So therapy has a very broad and deep meaning, so where it is more of a customized program. And when we are talking about stroke is every patient is unique. We have to respect the individuality and dignity of the person. So therapy has more of a customized way of dealing with a person. It is more of individualized. It is more of need-based approach when we are handling a stroke patient. Along with the physical dimension, we are definitely taking care of the mental dimension, and we are taking care of the posture, along with that body movements and activities. Coming to the word rehabilitation, another important thing. WHO definitely has defined rehabilitation as a combined, coordinated use of the physical, mental, educational, and vocational dimensions to train and retrain a person to get functional ability. National Council of Rehabilitation has furthermore expanded this to restore of a person of his individuality, integrity, so that he can once again integrate with the family and society with respect and dignity. And along this can be taken care of with the physical, mental, social, occupational, environmental dimension. So rehabilitation word has a great depth, right? So more than the therapy, the word rehabilitation. Now you have asked me about holistic rehabilitation. So holistic, as an holistic expert, I'm still a student of in holistic care. I'm still learning a lot. I consider still myself as a student. But here, definitely, in any neurological case, whenever there is sudden loss of movement on one side of the body or both the lower limb, the trauma is more at a psychological level. More than the physical disability, the trauma is more at a psychological level. Suddenly the person feels lost, the person feels worthless, the person starts feeling hopelessness, the esteem goes down, the person starts feeling insecure. So here, when we talk of holistic rehabilitation, uh, we as therapists can do wonders by approaching them. And when we use the word approach, definitely, we are taking the feedback, we are understanding the person's situation, we are understanding the patient's background, maybe financial, maybe environmental, maybe occupational, and then we are trying to summarize or reach to a definitive therapy program, which can definitely uplift the morale and identity of the person. The person starts feeling more confident. That is the concept of holistic rehab, where along with the physic, the mental status and the spiritual dimension is taken into consideration. So when I'm focusing on spiritual dimension, I'm talking about the concept of self. The self feels threatened. So self-esteem and self-confidence needs to build up. And once that self-esteem and self-confidence build up, automatically normal postural reflex can be triggered. The person will have zeal and enthusiasm to participate in the activity program, and rehab becomes more an easy thing. The consequences of the problems that a person can face can be a little bit diluted, and the person feels little worthwhile to again face the challenges that are coming to him or her to for his life situation. So treatment is too physical a concept, biological approach. Therapy is definitely physical along with that emotional and mental, keeping in mind the postures and the body movement. But when we talk of holistic rehab or holistic care, definitely it is the self-esteem, self-worth, self-respect, along with taking care of the behavioral problems that a person may go through, understanding the emotional needs. And definitely, if these are taken care of, the physic definitely cooperates and participates to the higher level of functional goals. And this is the era of neuroplasticity. This is the era of neural functional reorganization. So functional rehabilitation is the area which is directly related with our need-based approach, eclectic approach. Okay, use it or lose it, use it and improve it. Specificity matters, age matters, transference matters, interference matters, right? So taking help of the neuromuscular plasticity and functional reorganization, going to a need-based approach, I think so. We are doing a total rehab protocol in our patients program, right? Hope I am not being too lengthy in my answering, but when it comes to rehabilitation, I always feel like sharing as much as I can so that we can do the best for this population. Thank you.
Thank you so much, ma'am. It's always pleasing to our ears to listen to you, and you almost covered all the terminologies we needed to understand. My next question is to Dr. Mahesh sir. Sir, can you share some idea on some precautionary measures related to Ayurveda to prevent stroke, according to you? And it's how gonna impact the quality of life of individual?
Uh, Thank you for asking. Again, as a preventive module, okay. As a preventive module, we are having a separate set of protocols, so which we call it as a dinacharya and rutucharya. That means daily regimens and seasonal regimens. One who is following daily regimens, it is been said that he will be swastha or healthy throughout his lifestyle. And there are set of protocols that starting from the early bed, what he has to do is being told, and until he goes to sleep, that much protocol, that much specifications are being told. And it is not as such it is very lengthy or it can't be done by anybody. It can be very easy and it can be done throughout the day. And for us it is as same as what we are doing, little change in the specifications. As such, when we start telling when to wake up, it is been told that it should be in Brahma Muhurta, that is been early the sunrise, that means around half an hour to 45 minutes early the sunrise. Then afterwards, so go for the Achamana, that is facial wash, and then same. These all protocols are being told. What I need to suggest is that following this protocol, it has been there in all the Google areas. We can just search it as a dinacharya. It has been a lengthy protocol. It's around 80 number of dinacharyas are there. Just like Achamana, Dantadavana, and Jiva Nirleka, Nasya, Pratimarsha Nasya. Then afterwards, yoga abhyasa, then Snana, then this prayer. There afterwards, Ruti Dharma. It will be around 6 hours or 8 hours. There afterwards, regarding the Ahara, here for Ahara, there has been some specification that Ahara should be Shadrasa Yukta, that means in Ayurveda, we consider the ahara having six different kinds of rasas, which is like Madura, Amla, Lavana, Katu, Tikta, and Kashaya. And it has been told that the person should take the ahara having all these three rasas. If you start taking only single rasa, that is Madura or that is Katu, Katu means pungent and Madura means sweet. If he goes on taking the sweet, then he will end up in diabetes kind of things. And if he go on taking Katu, then he will end up in acidity kind of things or the IBS kind of things. So it should be a complete ahara. As a complete ahara, the ahara should contain all these six rasas. There afterwards, then this Sayankala, this one, therapy, karmas. That means Achamana again. Thereafter was this Pratimashanasya, then Pratimashanasya, then again this holy blessings or the prayers. There afterwards, we can adopt the some walking and all. And then it has been told that after having food, we need to just walk for only 100 steps, and before that we can walk. That means if you are habituated to take the walking, it should be done in empty stomach. There afterwards, we need to have a light food and we need to go for the bed. And after that, bedding time should be within 8 p.m. Then, it is helpful to get up in the early morning. This is regarding the dinacharya. And regarding the Rutucharya, here in Ayurveda, we've been classified the whole year into 6 Rutus. As we all know, that is what is meant by Hemanta Rutu, Vasanta Rutu. These all 6 Rutus are being told according to the, particularly in a year. So, in each Rutu, what kind of things to be taken and what kind of things to be contradicted is being told, and we have been practicing here. And if the person is having some kind of any kind of disease, then we suggest them in which month they need to go for panchakarma regarding his disease. That means in Vasant Ritu, which comes around March month to May month, there we need to go for kapha dosha nirharana. That means the things, the disease which are been originated from kapha dosha, I mean to say this obesity and hypertension and diabetes mellitus and all of this granthi vikara, that means glandular diseases. You can take it as a hypothyroidism or hypothyroidism. All these things, even PCOD, that can be dealt through the woman karma. And afterwards, the next Rutu comes, that is Varsha Rutu of the Pravrut Rutu. There the month goes for them as the rainy season, that is early rainy season. That means July month to towards the August month, June towards the August. There we need to go for Basti Karma. And here for Basti Karma, through Ayurveda, what we suggest is the person who are going towards the old age, that means after 50 or after 60, they are being indicated for the set of Basti Karma, that means for 5 days or for 15 days or for 9 days. These set of Basti Karmas are being told for them. And again, for Sharad Rutu, the disease which have been happened due to Pitta dosha, that means all the GI tract diseases. It might be a Grahani or the this what we call IBS syndrome or Atisara, dysentery or skin disorders. These all beings taken care through the Virechana Karma, and this Virechana Karma should be done in Sharad Rutu, particularly in Diwali or in post Dasra and Diwali. That means what we are having present months, that is September to November, these are being given emphasizing for Virechana Karma. So the person who are healthy, they also can go for this Shodhan Karma. Or the person who are having little symptoms or in predominant symptoms, they also can take these Shodhan Karma. So, after taking this Shodhana Karma, the root cause of those diseases will be eliminated, and it has been understood that further happening of this disease or the further origin of this disease will not be seen in the particular persons, those who undergone Shodhana Karma. These are all the set of treatment as a Rutucharya and Dinacharya. And afterwards, Sadruta Palana. Here, Sadruta Palana means one should not take unhealthy, unwholesome foods throughout his lifestyle, and one should not do what is been told not to be done. That means all the contraindicated things should not be done by the individual person. Then you can take it as a taking a lot of sweets, taking a lot of fried items, or doing Ratri Jagarna, even though we know that it should direct towards the any origin of the disease. Still, we are doing as a student or as a professor, as or a technician, IT technician. It should not be done because it will end up in skin disorders. It will end up in hypertension. It may end up in hypothyroidism. It may end up in many disorders. So better these kind of set of things which are being told in Ayurveda should not be done by each and every person. That I need to explain. Further, all the things that yoga and pranayama should be done for each person, as because it has been suggested from the ministry also, and from it has been practiced since many years also. One can adopt just a Surya Namaskara that will be helpful, very beneficial for each and every person. I hope I told everything. Still, there is a lot of things, but we can't go one by one serially as a restricted time. So, thank you. If there is anything,
Thank you
then
so
let
much,
me know.
sir. It was really helpful, and I guess all the youngsters are taking all the contraindicated items right now. So I request all the attendees to please go on changing your diet plans and please focus on your health because it's really important for us to be fit if we want to treat patient perfectly. Thank you all the panelists for your time. And now I would like Dr. Bhavna ma'am, who is the principal of Parul Institute of Physiotherapy, Parul University, to present vote of thanks. Over to you, ma'am.
Thank you so much, Simra. And I must say that this kind of panel discussion, really called a panel discussion, where a very fruitful conversation and discussion happens on stroke rehabilitation. And as we have targeted this panel to give holistic approach about the stroke and stroke rehabilitation to the viewers and the listeners, and this had really done it in a way what we have thought of. So, on behalf of Parul Institute of Physiotherapy, Faculty of Physiotherapy, and Parul University, I would like to extend my heartful thank to Ankit sir, respected Nilima ma'am, and Mahesh sir for sharing your valuable experiences, not just knowledge, but the experiences which actually matters for the rehabilitation. And I'm sure all the viewers and listeners might have got or correlated some or other things with their patients, and this would be very much fruitful for the further uh, treatment for the stroke patients. So, thank you very much, all of you, and on behalf of PIPT, it's really a pleasure to have you on this webinar, on this panel discussion. Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, all of you. With this, we end our panel discussion here.